faculty members and delegates to the virtual webinar of I-OSI on checkpoint inhibitors and treatment of NSCLC. Also, for a great start, I would be happy to inform you all that we have 190 registrations from all over the world. With that, I would like to invite our I-OSI President, Dr. Hemant Malhotra, sir. He is a professor and a head in the Department of Medical Oncology at Mahatma Gandhi Medical College and Hospital in Jaipur. Over to you, sir.
Thank you, Anshika, and my very good evening to all the delegates who have joined this meeting, and greetings to all of you on Teachers' Day. As a teacher of more than 35 years standing, I'd like to welcome you all to this webinar. As medical professionals, particularly as oncology professionals, we are always students. We are always learning. Our field is evolving, and Chiplunkar, which all of you know. As a part of the educational activities of our conference, we have decided that we will do every 2 or 3 monthly webinar where all of you will be invited, and we will take up various topics of clinical interest and lab interest. And from next topic onwards, we will make sure that we have both talks in each webinar, one on the clinical aspects of a particular disease, and then on the laboratory aspects of the immunology and the immunotherapy of that disease. So for starters, we have decided to have a talk on checkpoint inhibitors or immunotherapy in the treatment of non-small cell lung cancer. And it is like a great privilege for us to have one of the top experts in the world to give this talk. So the program director for today's webinar is Dr. Shubhda Chiplunkar, ex-chief of the ATRAC at Tata Memorial Cancer Center, and the founder president of the Immuno-Oncology Society of India. So I'm going to hand over proceedings and the mic to Dr. Chiplunkar to take today's activities forward. Over to you, madam.
Yeah. Thank you, Dr. Malhotra. Good evening and happy Teachers' Day to all. I would give a brief introduction to the webinar and the topics of the webinar series, which Dr. Malhotra has already mentioned, how we propose to hold this webinar. Now, considering this growing landscape of cancer immunotherapies today, there is no denying that immunotherapy has taken a center stage in the treatment of cancer. Harnessing the immune system has led to the discoveries or emergence of technologies like checkpoint inhibitors, CAR T cells, and now antibody drug conjugates, the bispecific T cell engagers, and with the discovery of neoantigens, a lot of cancer vaccines, though they are all in clinical trials. However, we all know that immunotherapies only work in a subset of patients and in particular malignancies, of course, depending on whether they are hot or cold tumors. There are several challenges, like overcoming resistance to these therapies, identifying the target antigen, especially in case of cell therapies, overcoming immune evasion mechanisms of the tumor, and in cell therapies, the persistence of the engineered T cells administered to the patients, and so many more reasons. Moreover, we do not have robust, good biomarkers to upfront understand who are the patients who would respond to these therapies. So in this context, what is important is understanding the tumor microenvironment and the challenges the microenvironment imposes, and which becomes rather a major hurdle for the functioning of the T cells or the immune cells. So there is a lot of factors which are released into the tumor microenvironment. There are metabolites. Moreover, there is a mutational load which is there. And all these contribute to sort of functional exhaustion of T cells in the tumor microenvironment, and we need to understand that. A new and emerging area is the gut microbiome, and we now know that it is acknowledged for its role in dictating the response to immunotherapies. There are clinical trials going on with fecal transplants along with the immunotherapy. And I feel the future of immunotherapy is going to be shaped by expertise coming from various disciplines like nanotechnology, from biomaterial scientists, genomics, bioinformatics, and computational biologists who are going to use the big data, the genomics and the proteomics data, and get it translated to the clinics. So these are the emerging areas. There are new challenges which have to be overcome. And these technologies will help us to overcome, hopefully, these challenges. Finally, we cannot ignore the importance of health economics in treating our patients with these at present unaffordable therapies. So all these topics will be addressed in the forthcoming webinars, which we plan to do, and we will be inviting clinicians who have a lot of data generated on checkpoint inhibitors, also on CAR-T cells in the Indian scenario, and also from overseas. We would be discussing all this data. There would be basic scientists talking about the complexities of the tumor microenvironment and showing also the preclinical data, which can hopefully be translated to the clinics. So I urge you all to tune into these webinars, become members of I-OSI, and I'm sure it will be an enriching experience for one and all. So thank you once again and welcome to the webinar series. Over to you, Dr. Jyoti.
So thank you very much, Madam. And indeed, it is such an auspicious day. I was just mentioning that on the occasion of Teachers' Day, we are having this re-beginning of our webinar series. And who could be more, more appropriate to begin this than Dr. Chiplunkar, who's actually the teacher and mentor for generations of oncologists and immunologists. So it's an extreme pleasure and privilege for me to begin this series on behalf of Immuno-Oncology Society of India. And stage has already been set by Dr. Malhotra, who's the current president for Immuno-Oncology Society of India, and immediate past president, Dr. Chiplunkar. And I'm having a pleasure and privilege to introduce the speaker of today. And it is Dr. Kumar Prabhash. And I don't think he really required a formal introduction in the forum of immuno-oncology or oncology for that matter. But for the sake of it, I would like to say that he's a professor and head of solid tumor units in Tata Memorial Hospital. He's the current honorary secretary of Indian Society of Medical and Pediatric Oncology. He is the executive committee member for Immuno-Oncology Society of India, a great academician and researcher with several years of experience and several hundred articles to his credit. And more than all this, he's a very dear friend, collaborator, colleague from TMH for many years. We associate really well. And also, in a lighter vein, we always call him that he's a troubleshooter. Whenever there is a trouble, we can reach out to him and he will be having some solution. So over to you, Dr. Kumar. Stage is yours.
Thank you, everyone. Slides, and as usual in today's era, it is visible. I hope it is visible.
Yes.
And it's full screen and I am audible.
Yes.
So thank you. I thank I-OSI for inviting me for this lecture. And I thank all the organizers for the same. And my topic is for immunotherapy, and that's primarily, I do understand that's a checkpoint inhibitor in non-small cell lung cancer. I know, especially I was told for advanced stage, non-small cell lung cancer. That is what I'll be talking about. So new adjuvant and chemo radiation, that's not the part I'll be covering today in this lecture. Starting with the immunotherapy. So this is primarily a treatment modality which modulates the immune system. Now, there are whole different ways of having, way to modulate the immune system, and especially which works in lung cancer. And that's what I'll be talking about. So there are monoclonal antibodies, which can target and destroy the specific antigen in the tumor cells. We have immune cells modulator. This utilizes the protein produced by WBC to produce the immune power in the body, for example, interferon interleukins. Adoptive T cell therapy. There we remove T cells from the blood get the receptor in the ligand ingrained into the patients, and they destroy and stop the growth of the cancer cells. Immune checkpoint inhibitor, that will be primarily the topic for today, that prevents the cancer cell from further development or increases the immune system to fight against and destroy the cancer cells. And we have those PD-1, PD-L1, and CTLA-4 inhibitors. Therapeutic cancer vaccine. This is designed to help the immune system to recognize and destroy cancer cells by exposing it to antigen, which are protein produced by cancer cells. There had been a lot of work in this area, very limited benefit, but it appears after the advent of checkpoint inhibitor, which is fairly effective, there is a renewed interest in this area, and we'll be seeing many more work in this area in future. Then we also have dendritic cell therapy, which is used in tumor, especially in bladder cancer. Nothing much at this moment in lung cancer. Then lung VAX, that is carries a strand of DNA that trains the immune system to recognize new antigen on the abnormal lung cells. Again, something which we'll be looking in near future. Then we have vaccines like GP11 melanoma vaccines that contains an enhancer agonist epitope. Again, something at this moment we are looking for something beyond immune checkpoint inhibitor, and these are the mechanisms which people are exploring to combine with immune checkpoint inhibitor, which is at this moment effective in lung cancer patients. Coming to immune checkpoint inhibitor, they are a type of immunotherapy. They block proteins that stop the immune system from attacking the cancer cell. They are a treatment for cancer such as melanoma, which is a type of skin cancer, lung cancer, and many more. And in today's time, I call the immune checkpoint inhibitor of today's era is a bit like a paclitaxel of our era. I'm a fairly old person. So in our era, the way paclitaxel was explored and used in multiple tumors in multiple situations, and that is the kind we are seeing the immune checkpoint inhibitor in today's time being used. And I keep telling my students, learn more about it, because in your time, it will be in almost all the cancer, you will end up using them in some way or some form. So it is important to learn these immune checkpoint inhibitor. In today's time, which is they're available for us, especially in our country, and that is CTLA-4 inhibitor. Not all of them, at least one of them, PD-1 inhibitor. These both of them, there are many more from Western world, and especially from China, which is not available, but we are looking for some of them to be available in near future in India. And PD-L1 inhibitor, again, two of them, atezolizumab and durvalumab, which is available in India. If you see, I know, and showing those examples which is available, and I think in this one, ipilimumab is missing. This is available in India, which we end up using in many situations. How do immune checkpoint inhibitor work against cancer cell? Immune checkpoint inhibitor, they are proteins such as PD-L1 on tumor cells and PD-1 on T cells. They help keep immune responses in check. And this is a normal mechanism. This is to see that our immune cells doesn't attack our normal cells. But this is also a way the cancer cells take the advantage of and creates a camouflage for themselves, and our immune cells, they are not able to identify those tumor cells. And immune checkpoint inhibitor, what they do is, if I talk in layman term, is that they remove this camouflage and allows the immune cells to recognize this tumor cells as a foreign body, and they are trying to eliminate them. Yes, and this is the way this mechanism works. And in many tumors, it has been able to improve the life of the patient, increase the life of the patient. And now we are having data in more than one tumor where they are adding life to the patient in adjuvant setting, meaning improving the cure rate of the patients. Coming to biomarker, there are many of those potential biomarker, but at least 3 of them, which is used, and some of them very commonly used, that is the PD-L1. In spite of being a reasonably good marker, lots of flaws, it remains the most commonly used biomarker for immunotherapy. TMB, that is based on sequencing data. Looks like reasonably good marker with whole lot of flaws. MSI, a very good marker used in many tumors. The problem is that not many tumors has high MSI, but if it is there, it looks like it is a good predictive marker in many tumors for immunotherapy or checkpoint inhibitor to work. The data in lung cancer specifically is limiting, but MSI is tumor agnostic biomarker, so it can be used, but usually we don't because MSI high patients are far and few in lung cancer patients. Coming to PD-L1 as a potential biomarker, as I suggested that this is the most commonly used biomarker, and what it suggests, it is a bit of a continuous, the biomarker, which is a variable, which the prediction for responses are that more the positivity, more the chance of that tumor may respond. Does that mean that if the PD-L1 is negative, they don't respond? That is not the case. And that's why, remember, I said this is a good biomarker, most commonly used biomarker, but whole lot of flaws, which we use it, but we keep criticizing it. So it is important. And many of the tumors, this is the biomarker basis based on which this immunotherapy is used. So it is important to know about this. Some of those examples that why we look towards this biomarker as showing you, that is a keynote 407. That was a first line immunotherapy trial in squamous cell non-small cell lung cancer, and showing that based on the marker, higher the biomarker, looks like the chances of benefit of therapy also increases. Another example, Empower 131, again a PD-L1 based biomarker. Here it is a bit complicated. They have biomarker in tumor tissue and also on immune cells. And it appears if you use this combination, again, it is predictive of the chances of patient more responding to immunotherapy than as compared to not responding to immunotherapy. What it suggests that, yes, PD-L1 biomarker is important. As we go by, we'll learn that in lung cancer, where it is important to use. Coming to tumor mutational burden, this is one of the famous trial, and this is the review based on all the TMB based biomarker and the drug which has been developed. It looks like it is a tumor agnostic biomarker. Based on this, you have a drug approved in the clinic. But again, I need to highlight that it appears that if TMB is high, not necessarily every tumor has a similar prediction for therapeutic advantage. So be careful as far as this biomarker is concerned. And this is again a perspective where what it highlights how this TMB biomarker has been explored. If we go to the original article, I'll request people to read that. If you take the trial based on which the pembrolizumab was approved for a TMB-based biomarker, the mechanism how TMB was developed in that trial, it is not described. But here what the review suggested, how people have used the different ways of calculating the TMB as a biomarker. So again, highlighting the importance that when you're using a TMB as a biomarker, be careful what kind of data is available. What I can share that for the TMB as a biomarker, you require at least 1 megabase of product of the mutation analysis. So you have a panel of mutations which you are testing in patient. Unless the product is of 1 megabase, remember the TMB data what you are getting will be more of extrapolation rather than the real TMB data what you get. And what it means, and this is for students and the clinicians, it means that unless in a panel, the mutation testing what we are doing for a lung cancer patient, unless the panel contains 300 to 400 gene which is there, you are not going to have the output or the product which has got 1 megabase. And think that, yes, if you don't have it, then the data what you're getting for TMB is not good enough. So the way the TMB gets calculated varies from different kind of panel being used, different the way the data is being analyzed, and that's why there is a challenge regarding TMB as a biomarker in the clinic. Now, coming to how the drugs were developed, starting with the phase 1 study. This was one of the initial study published in NAGM. This is the BMS molecule, and this is the obvious one that this is the nivolumab. And also highlighting the importance of biomarker here. And what we see here suggesting that, yes, looks like these were initial phase 1 trial, that if the drug given, it looks like it works. It also suggested that if the PD-L1 was positive, the chances of patient response was higher. If PD-L1 was negative, there were no response, but this was one of those trials. In future, we have seen that if the PD-L1 is negative, that doesn't mean there is no response. Some patients do respond. But this phase 1 trial did highlight importance of biomarker and also importance that this drug works in these patients where the PD-L1 is higher for nivolumab. Coming to nivolumab monotherapy for first-line treatment in advanced non-small cell lung cancer. And these were the initial patients which were included in phase 1 and phase 1 study. And again, it highlights that if you given alone those patients who were treatment naive in this setting, in first-line treatment, it appears there is a small number of patients, they do respond with this treatment. And also they did have a durable response to the first-line treatment. And that was something striking for immunotherapy in non-small cell lung cancer, which we now know that that is some one of the trait for immune checkpoint inhibitor in most of the tumor, that if the patient responds, they are usually long-term responder. Now, activity of this immune checkpoint inhibitor in phase 2 trial setting, again highlighting that in phase 2 trial when it was explored, it appears that there was reasonable responses, and you do have the patients where the disease control was prolonged, highlighting that yes, they were ready to be taken in the subsequent line of therapy. Showing the same data that if when they were used in the phase 2 trial, then they were objective response rate of around 20% odd in various tumor, which included non-small cell lung cancer also, highlighting that there was a potential to take this drug in future trials. There was some other phase 2 trial which was happening where the drug were used in alone and in combination, and highlighting that there was once the drug was tested in phase 1, phase 2 setting, showing that it has activity, and also showing that these have durable activity. There were a whole lot of parallel development happening, and here showing one of the way where the drug was developed, that drug was used in combination with chemotherapy or alone in various tumor, and it also included lung cancer, to see that this drug has activity or not. Showing the same thing in the format of data that yes, this drug and the combination had activity. If we take the development of immune checkpoint inhibitor overall in lung cancer, and that is from 2015 to 2022, what we see that initially you had pembrolizumab, which was approved in a second-line setting. Almost at the same time, nivolumab was approved in the second-line setting as alone treatment. Then pembrolizumab was approved in 2016 in patients with PD-L1 expression more than 50% at alone, and also atezolizumab got approved in second-line setting at the same time. Then subsequently, 2017, pembrolizumab was approved in first-line setting in non-squamous cell carcinoma patient in combination with chemotherapy. 2018, durvalumab got approved in unresectable stage 3 tumor post-chemoradiation as adjuvant treatment. Atezolizumab got approved in first-line setting in non-squamous cell carcinoma patient with paclitaxel, platinum, and bevacizumab. And pembrolizumab got approved in combination with non-small cell lung cancer patient with nab-paclitaxel and carboplatin. 2019, atezolizumab got approved in first-line setting in non-squamous cell carcinoma patients, with nab-paclitaxel with carboplatin. And also pembrolizumab got approved in TPS less than 1% patients as a single agent treatment. Subsequently, 2020, 2021, 2022, we have a whole lot of data which came in non-small cell lung cancer treatment for single agent immunotherapy checkpoint inhibitor, combination of checkpoint inhibitor like nivolumab and ipilimumab, You also get the data of nivolumab plus ipilimumab plus chemotherapy in this setting, and also for durvalumab and tremelimumab, suggesting that in due course, in this almost 7-8 years, we had immune checkpoint inhibitor going from phase 1 to phase 2 to phase 3 in second line trial setting to first line trials setting, and now you have the drug approved alone in combination with checkpoint inhibitor and in combination with chemotherapy in first line setting for various drugs, and we need to choose one of them for in the best interest of patient to see which fits our patients for the treatment. Starting with second line treatment option for non-small cell lung cancer patient for checkpoint inhibitor, atezolizumab was compared with docetaxel. In this trial, a large randomized trial where squamous and non-squamous both patients were there. It were all comers. PD-L1 testing was done, but it was not required. And median overall survival improved from 9.6 months to 13.8 months. And PFS was not necessarily better, but we do know that is one of the limitations of checkpoint inhibitor, that not necessarily PFS improves in all tumors. Nivolumab was compared with docetaxel in checkpoint 017 trial, that was squamous cell carcinoma patients. The PFS was 2.8 months versus 3.5 months, not really significant, but overall survival, median overall survival improved from 6.0 months to 9.2 months. And nivolumab also was compared with docetaxel in checkmate 057, that was non-squamous cell patients, PD-L1 all comers. The PFS was 4.9 months and improved to 9.0 months. And then the median overall survival improved from 9.5 months to 12.2 months, which was again clinically and statistically significant. Pembrolizumab was compared with docetaxel in Keynote 010 study. They were again all like a OAK study, which was squamous cell and non-squamous cell, all patients were included. The PD-L1 positive patients were included. That was a bit of a difference from the other trials. And the median PFS was similar in both the arms, and median OS improved from 8.4 months to 11.8 months. What it highlights is that immune checkpoint inhibitor alone in second line setting in non-small cell lung cancer patient improved survival. Impact on PFS was not so significant, but as the impact on overall survival was significant, all these drugs got approved in second line setting. Here again the same trial showing the data in a tabulated format, highlighting that the overall survival was statistically significant, with hazard ratio being 0.62 in checkmate 017 study, 0.072 in checkmate 057 study, and 0.72 in Keynote 010 study, and 0.73 in OAK study, highlighting that almost there was relative reduction in death of around 30 to 40% if this treatment was used. Overall response, again, it was around 15 to 20% across the trial, suggesting that as far as the tumor shrinkage was concerned, a small number of patients did have it. Coming to first line metastatic non-small cell lung cancer, then the drug development. There has been various studies, and what I've tried to do is to club them in a way that we get a hang of it. We have a patients with a trial, what we call IPSOS trial, and this was a trial where chemotherapy, that is a platinum ineligible patients, were explored. Large randomized trial. Atezolizumab was compared with physician choice of chemotherapy, and it was a positive study in this setting. Empower 110 study, atezolizumab alone was compared with chemotherapy in PD-L1 positive patient. Again, this was a positive study, and survival improved in the patient if this was used. Then subsequently we had, not subsequently, at this sometime before that, we had Keynote 042 study, and this was a phase 3 randomized trial where pembrolizumab monotherapy was used in PD-L1 positive patients, and it showed that yes, if you do this, patients benefit with this treatment. Keynote 042 was again a phase 3 randomized trial. 024 was a patient with PD-L1 expression more than 50%. And 042 was PD-L1 expression 1% and more, and pembrolizumab alone was better as compared to chemotherapy in this setting. Then we had a checkmate 026. That was a phase 3 randomized trial for nivolumab, and it was compared with chemotherapy. And this was a negative study highlighting that not every immunotherapy or every checkpoint inhibitor is the same. You can't extrapolate the data of one drug with other, and we need to be careful about it. And it was a negative study for nivolumab. Subsequently, durvalumab was tried with as a monotherapy as compared to chemotherapy in a first-line setting, and again, this was a negative study. Subsequently, durvalumab alone was again compared with chemotherapy in patients of PD-L1 positive patients in non-small cell lung cancer, and again, it was not a positive study. We had another trial for cemiplimab, which was a drug where the primary trial was done in China, but subsequently also done in Western world, suggesting that alone, if we use in PD-L1 positive patient, it was better than combination chemotherapy. And also the subgroup analysis suggested that if we use in PD-L1 positive patient, which is more than 50%, then the survival was better. Then we have a Javelin study where the PD-L1 positive patient avelumab was explored, but that was not the positive study. Again, from my side, highlighting that all checkpoint inhibitors, they are not interchangeable. They have certain activities in certain tumors, and we need to use them in those certain tumors. Now, clinical efficacy and safety of checkpoint monotherapy in squamous and non-squamous cell lung cancer. Taking that data further, that was the trials which I showed, and what kind of benefit we have. Atezolizumab, when compared to chemotherapy, the median median survival improved from 13.1 months to around 20.1 months. PFS improved from 5.0 months to around 8.1 months. For pembrolizumab, in Keynote-042 study, the median overall survival in TPS that more than 50% or equal to 50% improved from 12.20 months to 20 months, and PFS improved from 6 months to around 7 months. In Keynote-024, the overall survival improved from 14 months to 30 months, and median PFS improved from 6 months to 10 months. In cemiplimab study, the median overall survival didn't reach as compared to 14.2 months, and PFS improved from 5.7 months to 8.2 months. Showing the same that was for alone checkpoint inhibitor. Now, checkpoint inhibitor has been also explored in the setting where they have been combined with chemotherapy. So what we see here on Keynote-021, pembrolizumab was combined with chemotherapy as compared to chemotherapy. Keynote-189, pembrolizumab again was combined with chemotherapy in non-squamous cell lung cancer patient and compared with chemotherapy. Then we have a atezolizumab where it was combined with chemotherapy and compared with chemotherapy, and showing a whole lot of dozens of studies in this kind of trial. What are highlighting that, yes, you have a pembrolizumab, you have a cemiplimab, you have atezolizumab. They have been explored in many situations where they have been combined with chemotherapy and compared with chemotherapy. And if we see checkpoint 227, where immune checkpoint combination was compared with chemotherapy alone. If we take when the combination of chemotherapy, they were not positive, but when the combination of only checkpoint inhibitor was concerned, then checkmate 227 trial was positive. But also highlighting that again in the combination trial setting also, not all trials are positive. For example, Neptune trial, where durvalumab was combined with tremelimumab in first-line setting, it was a negative study. Mystic study, again durvalumab combined with tremelimumab, again it was a negative study. Highlighting that you do have trials and you do have combinations, and these combinations needs to be seen in those specific situations to use it, and we shouldn't be exploring all the patients, all the immune checkpoint inhibitor as the same. Coming to this was what I talked about overall immune checkpoint inhibitor in lung cancer. Now we have very specific groups where immune checkpoint inhibitor has been explored, and the question always remains, do we have the activity? So you do have some data regarding immune checkpoint inhibitor used in EGFR mutation positive patient. there are various randomized trials. One of them was Empower 150. If you take the subgroup analysis of Empower 150, and what it suggests that if you have EGFR mutation positive patient, and if you use atezolizumab with chemotherapy and with bevacizumab, then it improves outcome for these patients. Otherwise, alone using in combination with chemotherapy, it does not improve survival for these patients. I need to add here, beyond this, there are two randomized trials which compared immune checkpoint inhibitor with chemotherapy as compared to chemotherapy alone in EGFR mutation positive patient, and they are a negative trial. So I need to caution people that we should not be jumping the gun when we are using immune checkpoint inhibitor in EGFR mutation positive patient. Showing the same thing here, that yes, if you want to use it, then you can use atezolizumab, and this is for PFS data, which was also better with chemotherapy plus with bevacizumab. Showing the same thing that yes, the overall survival also was better for the same for EGFR mutation positive patients. Before going to other clinical situation, adding that I have not put the data because of the sake of the time. This is the similar situation for other immune checkpoint inhibitor for checkpoint inhibitor in driver mutation positive patients. So if you have a driver mutation positive patients, be careful about using checkpoint inhibitor. If you take EGFR, ALK, ROS, MET, then the activity is very limited, and one should not use in first line, maybe not use in second line, and may consider in beyond setting. But if we take KRAS mutation positive patient, there is a good activity and this needs to be used. For BRAF, for other RET and NTRK mutation positive patient, maybe one can use in first line setting for these patients. Coming to specific clinical situation, we come across and we always have a question: do the checkpoint inhibitor, they have an activity when we have a brain mets patients? Showing the data here that if we have a brain mets patient, then you do have a reasonable activity of immune checkpoint inhibitor. If you take ICR, that is intracranial responses, you don't have reports from all the trial. From the trial, what you have, it appears that you do have intracranial responses of around varying from 20% to 40% in these patients if immune checkpoint inhibitor is used, suggesting that in spite of being a big molecule, that is an antibody, there is a reasonable activity of immune checkpoint inhibitor in this setting. That doesn't mean to say that I'm suggesting that if you have a brain mets patient, then omit radiotherapy. No, radiotherapy needs to be considered in appropriate patients. But yes, you do have activity of these of checkpoint inhibitor in this setting. Now, does it matter that liver mets is there or not as far as checkpoint inhibitor activity is concerned? It appears that liver mets is there or not, checkpoint inhibitor as far as the relative benefit is concerned remains the same. Overall overall liver mets patient, they may do poorly as compared to the patient who doesn't have liver mets. The proportion benefit of checkpoint inhibitor remains the similar. And again, we need to consider a checkpoint inhibitor in the patients we are appropriate in if they have a liver mets or no liver mets. There has been a lot of work and trying to find out, does it matter as far as the liver mets is concerned, and also the relative benefit of checkpoint inhibitor is concerned. What is relatively certain that yes, if you have a liver mets, then overall prognosis of these patients are poorer. But as far as the checkpoint inhibitors are concerned, the relative benefit of these patients remain, and this needs to be used. Showing the same thing with multiple trials where this was analyzed and the data being available. So as far as the liver mets is concerned, checkpoint inhibitor needs to be used. Coming to poor performance status patients, do we use a checkpoint inhibitor when the performance status is PS2, 3, or 4? We do know that as far as the chemotherapy is concerned, we have not been using chemotherapy in the patient with poor performance status patients, and primarily because they are fairly toxic. As far as the TKI is concerned, because it's safer and effective, we do use it routinely. As far as the immune checkpoint inhibitor is concerned, this is a safe drug, and that's why there is a renewed interest in the poor performance status patient and trying to find out if the immune checkpoint inhibitor has activity or not. This is one of the work which we did, and what we found that these were the patients which we used in which were there in the study. And what it suggested in our study that yes, poor performance status patient, there is a small activity, but there is activity in our patients, but activity is smaller than as compared to what we have seen otherwise. This is the randomized trials where you have those patients with PS2 patients which has been there, but most important is this is the study where we analyze the data regarding immune checkpoint inhibitor. This is from our study where we had the poor performance status patient compared where they used checkpoint inhibitor and where they didn't. It appears that immune checkpoint inhibitor has some activity. And if you further subgroup the performance status 2 versus performance status 3 and 4, then it appears that PS2 patients do better as compared to PS3-4 patients. So it appears the PS remains one of the most important biomarker in almost any tumor, and it also includes in lung cancer patients. Now, do we have a randomized trial evidence that in poor performance status patient, checkpoint inhibitor works? Yes, this is a randomized trial called I-OSI study. Almost 400 plus patients who were randomized between immunotherapy versus chemotherapy of physician choice. And it appears as far as the response rates are concerned, it was higher. And as far as the overall survival was concerned, it was higher with hazard ratio 0.78, with p-value being significant and clinically relevant. So in poor performance status patients who are not fit for platinum-based chemotherapy, immune checkpoint inhibitor is a viable option and with a reasonable activity in this setting. And at 2 years, the overall survival improves from 12.4% to 24.3%. That is almost absolute benefit of beyond 10%. Coming to safety profile, and in this poor performance status patient also, the safety was better as compared to chemotherapy, and that is also expected. But chemotherapy usually they have more toxicity. Apart from that, immune checkpoint immune checkpoint inhibitor related toxicity remains, and that remains whenever we use it. Now, coming to checkpoint inhibitor in autoimmune disease, and we always have a concern that if you have autoimmune disease, can we use immune checkpoint inhibitor or not? Initially, in trials, they have not been included, but there has been lots. There have been now good number of retrospective study, and what it suggests that if you have autoimmune disease, if it is well controlled, then yes, checkpoint inhibitor can be tried, but be careful. There can be fair number of exacerbation in these patients. Again, highlighting there are a whole lot of data now available. Again, retrospective data. You won't get a randomized trial data suggesting that if you have autoimmune disease well controlled, you can explore it. Be careful about the flare. Remember, these patients can have a flare, so you have to monitor them more closely and see that they don't end up having in trouble because of autoimmune disease when we use immune checkpoint inhibitor in this setting. Can we use a checkpoint inhibitor in solid transplant patient? And that is something we need to be very careful. Chances of rejection is very high, and at this moment, one needs to be very, very careful before using immune checkpoint inhibitor in this setting, because there's a very high chance of patients losing their organ. Can we use checkpoint inhibitor in patient which is immune deficient? And the data comes from a patient having HIV infection, and it appears that as far as the immune deficient patients are concerned, the benefit of checkpoint inhibitor remains similar to what we have seen in immune competent patient. So if you have immune deficient patient, there is no contraindication for using this immune checkpoint inhibitor. So yes, one can use it, and that remains true for lung cancer patient also. So in conclusion, immune checkpoint inhibitor as an immunotherapy is now part of routine care in non-small cell lung cancer. because this was the lecture for non-small cell lung cancer in advanced stage patient. But I need to emphasize that now it is part of the routine care in adjuvant setting after surgery, is part of routine care before surgery as a neoadjuvant immunotherapy plus chemotherapy. It is also a part of routine care after chemoradiation in the patient which is mutation negative patient, driver mutation negative patient, especially for EGFR, ALK, and ROS after chemoradiation for non-small cell lung cancer. And yes, it has improved survival in many settings in non-small cell lung cancer. And in fact, this is the first time in non-small cell lung cancer we have started seeing that you have a survival 5 years and beyond when we use immune checkpoint inhibitor. With all the checkpoint inhibitor I showed you in advanced stage non-small cell lung cancer, all of them have shown now that beyond 5 years, you have around 20 to 30 patients surviving, meaning that 1 out of 3 patients goes beyond 5 years. If I talk about my era, when we had paclitaxel, then there were 5% or odd patients who used to go beyond 5 years, suggesting a significant improvement in survival in these patients, but also highlighting that these patients, there's a whole lot of unmet need, meaning that 2 out of 3 patients, they do die before 5 years, suggesting that a lot of work needs to be done. Thank you. Thank you so much. We'll be happy to take if there's any questions.
Thank you so much, sir, for such a wonderful talk. Now, our online audience is requesting you for your slides so that we can put it on our I-OSI website. So I would like to take your permission, so if we can share slides on I-OSI website.
Yes, please do it.
Okay, sir. So if you can share me the slides, I will
do that.
Thank you so much, sir. Now, I would like to invite Dr. Jyoti for discussion.
Thank you very much, Dr. Kumar, for this was wonderful session. And Anshika, can you post the questions?
So there are quite
I could see
questions on the chat
Hello.
box. Maybe Jyoti, you can check them
Oh,
out.
I can see the question. Can I take the question and answer
Yeah,
if it is okay?
Yeah, please,
sure.
please, Kumar, go ahead.
Okay. So Hridesh has asked, what is the mutation frequency of PD-1 in ALK positive non-small cell lung cancer, and can the MAP kinase inhibitor help? So a PD-L1 expression in ALK positive patient is fairly high, but what we call it is redundant. Means that if you have an ALK positive patient and if it is a PD-L1 positive, then they don't respond to immunotherapy, and usually they don't. And so I'll say preferably don't use it. Definitely not in first and second line setting, maybe not in second, third line setting also. Maybe beyond one can try it, but usually they don't benefit with it. In liver mets cases, can SRS circumvent IO, and whether PD-L1 status can be deciding factor in these cases? Yes, I do understand that SRS as a part of treatment, and also they being synergistic to IO therapy has been a matter where a lot of people are working it. Not necessarily we always have got a positive result. There was a positive result, and this is the data comes from limited stage non-small cell lung cancer. SBRT with immunotherapy was better than SBRT, but subsequently just now the phase 3 randomized trial data has come, and that came just around a week back, and that suggests it is a negative study. Similar data has come in head and neck cancer, SBRT combined with immune checkpoint inhibitor, and hoping for an increased activity, which is not true. So can it circumvent it? Unlikely. Can it be used? Sure, it can be used in patient by patient, but not routinely for liver mets. But SRS, very good treatment for localized non-small cell lung cancer, especially if the patient is not fit for surgery. I have observed amplification and deletion of some of the immune checkpoint receptor around 2 to 10% of serous ovarian cancer. It can also be seen in lung cancer. It is possible, and I agree this is something which we need to explore. That is true. How you compare various immunotherapy options in first line setting, and what is the real world would be the criteria to choose? If we take the various immunotherapy at this moment in lung cancer, immune checkpoint inhibitor remains the only option. I know that this trouble will happen in melanoma now, till also being there. It will get complicated with the CAR T cell therapy getting explored in many other solid tumor. But at this moment, it is only checkpoint inhibitor. Out of the checkpoint inhibitor, we have at least 3 of them which can be used in first line setting alone. That is a pembrolizumab. Then you have a semipilimab, and then you have atezolizumab in the patient where the PD-L1 expression is more than 50%. Others, it is better to combine them with chemotherapy. And apart from that, you have a checkpoint inhibitor plus checkpoint inhibitor, that is nivolumab plus ipilimumab in first line setting, in depending upon various soft indicators where we can use it. But these are the treatment option which is available. Biomarker for response in first line and second line significance. In first line setting, if you want to use alone, then biomarker PD-L1 is very important. Otherwise, you can in combination, you can use it without having the PD-L1 testing being done. TMB and MSI, not so great in non-small cell lung cancer patient. One can use it. TMB, it may help you a bit, but not necessarily data is very strong. Preference of doing comprehensive NGS or small panel. NGS must, comprehensive or small panel, I leave it to individual clinician to choose from. The advantage of NGS is that you get TMB and MSI result in the same panel. Small panel, you may not get the report, but yes, one can question that, do we really require it? But NGS, yes, definitely one should favor it. Comment on off-label use of immunotherapy and medico-legal aspect. Off-label use is a routine way of treating patient. Off-label is not a routine way of treating patient. Label is required for pharma company to sell the drug. So for off-label use, you have a clinician discretion which can be used depending upon the data being available, where the patient safety is not compromised. You have a various guideline which can be used to use off-label drug. For example, cisplatin is not doesn't have a label for head and neck cancer, but remains the most important treatment in head and neck cancer today also, and without having any label. So efficacy and clinical guideline becomes very important when label is not there. Will you start immunotherapy with chemo or chemo alone till you get NGS? I'll start with chemo alone, because if you use immunotherapy before NGS report comes, then if you have a mutation positive patient, then you do have a toxicity. The chances of lung toxicity increases. So be careful. Better not use immunotherapy without having NGS result with yourself. So I think these were the questions which were there.
Cost and toxicity is the last one.
Oh, cost and toxicity. Okay. I'll put a ballpark figure to it. So you have, as we say, that almost 10% patient develop severe toxicity, and what we call, well, we end up intervening patients. 90% of the patient, they don't develop a severe toxicity. Almost 1/3 of the patient will have some form of toxicity, which you will end up giving some treatment on the OPD basis. So not so toxic treatment. Toxicity is mainly for what we call a bit of immune related toxicity, which is a bit related to these kind of checkpoint inhibitor, what we call itis, from arthritis to pneumonitis to nephritis. So it can happen any part of the body. But if you're careful, we have now used in few thousand patients, you may not lose patients if you are careful about it, which is manageable. Cost, I totally agree. I always tell my patients that it is obscenely costly. And that is where, as a clinician, as a society, we need to come together to develop many ways of decreasing the cost. One of the things which we have done, which we did in head and neck cancer, our lung cancer result, trial is on. But in head and neck cancer, we used 1/10 of the dose, decreasing the cost from 2 lakh rupees to 20,000 rupees for our patients, which can be used. And this was the first randomized trial ever in the world for low dose immunotherapy. Just putting this in perspective, that yes, there is onus on us as a clinician and researchers and society to develop treatment which is cost effective for our patient. But at this moment in regular dose, it is obscenely costly.
I think, extremely useful discussion, really meaningful, and many of the real world questions were also, proposed. So I think it was very, very useful for everybody. Many students also logged in. So I think quite fruitful. I believe this webinar series should benefit many more in the future. And I completely agree with you, Dr. Kumar, that as a society, we should take this initiative, across the country to initiate certain trials, collaborative trials wherein we can answer certain practical questions for ourselves, our problem, our solutions kind, and the cost effectiveness, or some of the use which are not labeled per se, but which are the common practice. Maybe we can systematically test those things and find some answers. So on this note, I would like to thank Dr. Kumar, and
So
if
Jyoti, there's
Dr.
another
Malhotra,
question.
Dr. Chupruga wants to say anything, then
There's another question, Dr.
There's another question. Maybe Dr. Kumar can take care of that, because it's very difficult and rare for us to catch hold of Dr. Kumar. So as many questions as we can have him answer. I know he must be tired and hungry, but
Yes, no, sir. I'm always, sir, sir, yoga. So, sir is a teacher to me, and it is his greatness that he thinks that I am important enough, and I was always look towards him to get him inspired and do things. And now the question to and answer to the question, ultra low dose immunotherapy. That is the first question. Yes, this needs to be explored. I can tell you this is one randomized trial which we published. Second randomized trial we have just completed, and that's a 500 patient randomized trial. That is alone low dose, ultra low dose immunotherapy. I say be careful. So 240 is the dose for nivolumab. So 200 milligram is also low dose. 100 milligram also is low dose. 40 milligram also is low dose. 20 milligram also is low dose. Now, which low dose is good enough? We are learning that not necessarily every low dose is good enough. Also, we are learning that every low dose alone may not be good enough. Maybe they require help. So I say be careful. What we know that low dose is a good way of going. If your patient can't afford full dose, think about low dose. But that doesn't mean with our study which we published, 20 milligram with chemotherapy. Remember, it was with chemotherapy was good. Is it alone? I'll say I can't share the data because it is it's getting analyzed. But I can definitely say that not all low dose is alone is good enough. So one needs to be a bit careful about it. Another question was regarding low dose radiotherapy. This is something, there is some good data about giving radiotherapy low dose and then give a break, give 4-5 fraction and see what happens. In head and neck, that data looks very promising. I don't say that use it. It is very useful for palliation, bone pain, other things. But if it turns out to be good, which looks like with this fractionated dose, low dose radiotherapy to be given in 4-5 fractions in head and neck cancer, that can be a very good solution for our patients for as an immunomodulator. But at this moment, good to do a research work on this. It will be good to do a trial. And that may be not very tough to do it because whole lot of places we have radiotherapy machines and whole lot of places we have clinicians.
So one last question is there, Kumar. How can you combine immunotherapy molecules?
Yeah. Sir, immunotherapy molecules, as on date, we have been struggling. There has been promising data for nivolumab plus ipilimumab. Apart from that, it looks like whenever we have combined other checkpoint inhibitor, and people have tried to combine with TIGIT, LAG, a whole lot of them. And now there is one promising data for melanoma. I'm sure Dr. Jyoti can comment more on that. But looks like all other places, it has been a bit of a struggle. There has been now, having what we call in one antibody two mechanism, like amivantamab. There is one molecule from China which has got anti-angiogenic activity and also has anti-PD-L1 activity. And that data is very exciting. And if that remains true, then we will have these various antibody having multiple activity being explored and having and may be useful. But at this moment, the what we thought that if you combine multiple checkpoint inhibitor, we will have all positive study. With failure of many trials, it has been a bit of a sobering, experience that we may have to find out other ways to make it better as compared to single agent checkpoint inhibitor at this moment.
So absolutely, I think we are learning to tame the beast, and beast is in different forms, in different tumors, and everywhere we need to augment the immune modulation in slightly differently. Perhaps vaccines along with and the personalized vaccines, what is coming up alongside checkpoint inhibitors could be a new era. When we move in this space, that looks a bit promising, at least in a few cancers. So with this, I believe that, everybody's hungry and we can only offer virtual dinner from I-OSI, which is not so much people look forward. So on this note, I believe I thank each and every one of you for your interactions and enthusiasm for this, re-beginning. And we will be doing this on regular basis. The next webinar will be in December, and Dr. Malhotra has already promised to take this. We will, in a week's time, we will announce the date as well. And, we look forward to your wholehearted participation. So thank you once more, Dr. Kumar. Thank
So,
you,
Jyoti,
Dr.
can I
Chiplundar.
request you to, tell everybody, and I'm so happy to say that there are 140 people attending this webinar. That is the draw which Dr. Kumar Prabhash has and the fan following which he has. And I mean, I'm unfortunately not a fan of his. I'm an air conditioner of Dr. Kumar. So, Jyoti, can you please elaborate on the conference, the annual conference of the
Yes.
I-OSI, which we are going to have?
Yeah, absolutely. So, thank you very much for this. So we will be having our annual Congress in January. So every year, Immuno-Oncology Society is having one annual national Congress. And this year it is in Bhubaneswar. Dr. Biswas, Ghanshyam Biswas and myself will be the co-organizer along with our entire executive committee and several other leaders from the country. And we are having privilege this time that Professor Jim Allison himself will be traveling to grace the occasion and giving the I-OSI oration alongside Dr. Pam Sharma, who is again a clinician and immunologist from MD Anderson, and two more eminent faculty members from MD Anderson and part of Cancer Moonshot program, Dr. Sangeeta and Dr. Betty Kim. So this will be an academic feast, and I urge all of you to please register. Right now, we are in the phase of early bird registration, and there are several, schemes for lifetime members. Also, if they become members, they will be having many privileges at present. So we really welcome. We want to welcome you in the historic city of Bhubaneswar in person and have a close encounter with Dr. Allison. So, Dr. Chiplundar.
Yeah. I just want to thank Dr. Kumar Prabhash for such an excellent talk. And I want to mention that when I was organizing his talk, when I just called him, he readily agreed, and he has done that earlier also. Whenever I've approached him for a talk, he's an excellent teacher, and no doubt he has a fan following, as Dr. Malhotra said. So thank you, Kumar, very much for an excellent talk and accepting the invitation.
Thank you, madam.
Let's give him a round of applause. Virtual
Yes.
applause.
Thank you. Thank you. No, I have many teachers here, and madam, I have worked with madam when madam was in ACTRAC, and she has been very kind to me always.
Right. So some people are texting me that, next topic will be more contentious issues in the real world. For example, like off-label use of drugs and with the legal aspects. So maybe we will involve Dr. Kumar again. Yeah. Thank you very much. And we can disperse. Thank you very much.
Thank you.
Thank you very much, Kumar. Really, truly appreciate it.